Hello, I'm Dr. Manish Singhal, medical oncologist at Apollo Hospitals, Noida and Delhi. We are presenting the ESMO update meeting. ESMO is European Society of Medical Oncology meeting, which was held this year in October 2023. This is a meeting which is attended by global experts across the world, and it provides all the up-to-date information about various cancers. And we are happy to announce that this meeting was held under the aegis of Apollo Hospital and was held on 4th of November at Radisson Blu, Sector 18, Noida. And we were able to invite faculty across Delhi NCR and all other cancer experts, which shared their views on these updates, and was attended by a lot of students. And I'm sure that these updates includes not only about breast cancer, lung cancer, GI cancers, gastrointestinal cancers, GU cancers, but also supportive care and sarcomas. It's so very important to keep up to date to provide the best possible care to our cancer patients. And I hope that you like these updates, and we will keep introducing more updates like this in the future. Thank you.
Evolving landscape of CDK4/6 inhibitors and the implications in the clinical practice. We heard in a lot of conferences regarding various CDK4/6 inhibitors, the points favoring one or the other, the differences and all that. So, in the nutshell, today I'm going to cover that and then give a gist of what these are to offer. So we all know that when considering the options of these CDK4/6 inhibitors in advanced breast cancer, what is the primary treatment goal? They were asked to oncologists, and the women were surveyed, and the answer given was just the overall survival. So that is the first goal of any treatment, any cancer treatment that has been offered. That's deemed as gold standard. So I don't want to go into the definition of what is overall survival. So then comes a question: are CDK4/6 inhibitors the game changers in the management of hormone positive versus negative? So this is an overview of CDK4/6 inhibitor landscape versus endocrine therapy. This is a schema of trial of 3 CDK4/6 inhibitors and the various trials involved in them, and the first line, the second line, and the patient disposition. So if you talk of the benefit of first line versus second line, nutshell, the first line has 2 years of benefit with the CDK4/6 inhibitors, versus half with only endocrine. In the second line is around 1 year. So what is important is the overall survival advantage. So overall survival advantage is seen with ribociclib and the abemaciclib. So, but in the abemaciclib, the monarchy is still pending. Across the board, ribociclib in the pre or postmenopausal on the first or second line setting has shown an overall survival benefit. However, palbo did not show the same. Can this PFS benefit be the predictor of OS benefit? That has also been answered many times, as in a lot of metastatic disease, we take PFS as an endpoint as the OS predictor. So why this? Because we have subsequent lines of second line, third and fourth lines giving the benefit of OS. So hence the PFS is taken as kind of surrogacy for the OS. But we have a lot of targeted agents. This has been repeated saying that yes, still OS should be a target at the end point. So if you look at this Paloma trial that is reputed, the PFS did not translate into OS. As you can see on the left hand side, there is a PFS set of benefit in film 2 and 3, and however there is no OS benefit. So what are the reasons for the differences in the PFS to OS benefits? So these are the hypotheses that have been put forward. Why amongst the various CDK4/6 inhibitors there is a difference in the PFS, and some OS are seen and some it is not seen, specifically palbociclib. So first hypothesis was different patient population in trials. The second hypothesis was different post-progression treatment in trials, and the third one was different pharmacological characteristics of CDK4/6 inhibitors. One by one, we go into the trials and then come to a conclusion which one is the better. So when we talk of the patient, the comparator arm, so we do not have a direct comparison trials between the palbo and the ribociclib. However, there is a matching adjusted indirect comparison that has been done. So between the Mona-Lisa and the Monarch. So if you can see the patient's randomization, menopausal status, so they all been stipulated, and then this MAIC was done. So that's basically a pre-matching, matching, and then the apply rate, and then after matching, we segregated around 100 odd patients in each arm of a palbo and a ribociclib. So once that was matched, we can see that the PFS was giving towards or favoring a ribociclib compared to the palbociclib. So also you can see the overall survival that also favors the ribo compared to a palbo, stating that this indirect comparison of the matched analysis showed that it was favoring the ribociclib. Hence, the different patient population trials with this indirect comparison, the evidence-wise it was adopted. So next, the different post-progression treatment goals, and then the third one is we come to the second one. So post-progression treatment, there was a pooled analysis of post-progression treatment after first-line ribo-endocrine therapy from Mona Lisa 2, 3, and 7 trials. So this has shown that a patient's most common subsequent therapy is between the two arms. Somebody who has received a ribo, endo, or only the placebo. So the subsequent line of treatment is different in these two arms. So for patients on endocrine therapy, on a ribo arm, endocrine therapy was the most common subsequent therapy like fulvestrant. That will be followed by chemotherapy. Somebody who has received a placebo, they have received a chemotherapy as the most common. That will be followed by endocrine therapy plus CDK4 inhibitor. So you can see this the bar diagram. You can see that the Mona Lisa study, the first and subsequent lines of during the second line. The first line we all know that definitely CDK4/6 plus ET is definitely favoring. In the subsequent lines, once the patient progresses and then you put them on the second line treatment, you can see the blue diagram still over and above the placebo or comparator arm, stating that is there any carryover effect of a ribociclib despite stopping it. So that is the point to be made. But how in a Palomar 3 trial, the palbociclib, though this was discontinued, showed a similar or numerically a shorter benefit in the next or subsequent line therapy. So thus negating the fact that this may not have the carryover effect. So the second point of a different post-progression trials and clinical trials with a possible carryover of effect of ribo was stated. Now coming to a third point of a different pharmacological characteristic of CDK4. This also has been talked in many conferences, saying that there is a differential inhibition of CDK4 versus 6. Where exactly CDK4 is present, where is CDK6? It's more stipulated and it's proven that CDK4 is present more in ER positive breast cancer. However, CDK6 is dependent more of hematopoietic in origin. So the CDK4/6 have a different activity towards the target. So 4 has been hesitant. If you can see the blue one, which is more with ribociclib,